With me today is Dr. Howard Schubiner. He's an internal medicine physician for almost 40 years, author and director of the MindBody Medicine Center in Michigan. Dr. Schubiner, thank you so much for your time.
Thank you for having me. It's a pleasure to meet you and to be here.
Chronic pain, it seems like an issue that I feel is underrated, but everyone seems to be in pain. The world seems to be, there's a collective body of pain that is it's disruptive and it's very misunderstood. Do you have statistics for me in terms of the chronic pain cases over the last few years?
Well, it turns out that chronic pain has risen significantly, some would say dramatically, in the United States, but also worldwide in the last couple of decades. There is no doubt about that. And it's not because of an aging population. The incidence of pain begins to rise. It occurs, obviously, some children, some teenagers, but most prominently in the ages of 30s and 40s and 50s. It tends to become, it doesn't go down that much with older people, but it's not rising with age. So it's not due to an aging population. It's not due to diseases of degeneration like arthritis or degenerative disc disease. We have a good sense of what we think it's due to, and we can talk about that. But there's no question that it's rising. In the United States, it's estimated that approximately 40 or 50 million people are living in chronic pain. When you look at disability worldwide, from the statistics from the World Health Organization, you see that the most common causes of death are cancer, heart disease, stroke, chronic lung disease, things like that, infections. But the main causes of disability worldwide are back pain, headaches, neck pain, joint pains, chronic widespread pain. And the other thing we know is that not only has chronic pain dramatically increased in society worldwide in the last couple of decades, but anxiety and depression have also increased dramatically worldwide in North America and around the world. And as we'll discuss, those things are probably related.
Your body of work and research, it's groundbreaking and quite extensive, but I'd like you to explain one of the concepts that seem to be at the very center of it. So your work is about the mind-body connection, how it relates to chronic pain, but mind-body syndrome comes up center. What is this?
Well, it's just a name that I've given, and many people have different words or names for what's happening when pain or fatigue or anxiety or depression or insomnia, when those symptoms are caused by the brain, as opposed to being caused by a physical condition in the body. And it turns out that our brain is wired so that when a physical injury occurs, the brain creates pain. But it's also wired for when an emotional injury occurs, the brain can also create pain or these other types of symptoms that are commonly seen and create a lot of disability worldwide. It turns out there's a new understanding of how the brain works, and this is called predictive processing. And predictive processing is the neuroscience theory, and this isn't a woo-woo kind of new age theory. This is neuroscience conception of how the brain works. I just want people to understand what I'm saying here. And this neuroscience conception of how the brain works is that our brain actually generates what we experience. We don't see with our eyes. Light comes in our eyes, but our brain generates the image. We don't hear with our ears. Sound waves come in our ears, but our brain generates the actual sound that we hear. And when you touch a hot stove, it's not your finger causing pain, it's actually the brain. And we know that because a lot of people can have injuries and have no pain. Mm-hmm. So it turns out pain is generated by the brain. And it's our job as physicians and everyone in society to understand that some people have pain because of physical injury and other people have pain because of stress and emotional injury. Mm. And once we understand that basic concept, then we can look carefully at each individual to help determine if their pain is actually being caused by their brain, by their body, or a combination of the two. And just to say, we did a recent, if you look at people with chronic headaches, 95 roughly percent of the time, there's no structural injury. Tension headaches, migraine headaches. If you look at people with chronic abdominal or pelvic pain, 90% of the time, there's no structural injury. And we recently finished a study with chronic neck and back pain where we evaluated 220 consecutive people coming to a doctor's office for chronic neck and back pain, and we determined that 88% were non-structural. This is a very high number, very high number. And most people would think it's insane or crazy or that we don't know what we're talking about. But we looked at these people very, very carefully, and that was our conclusion.
By what metric do you measure whether or not pain is chronic?
Chronic pain just means it's existed for a lot more than 3 months, and that's occurring, most days out of the week, or it keeps recurring and flaring up. Most of the people with chronic pain have had it for, not only months, but years or even decades. And they have eluded effective medical treatment. The traditional medical world is not very effective at treating chronic pain. The studies showing, pain medications, injections, surgery for chronic pain, stimulators for chronic pain, kind of standard talk therapy for chronic pain. None of those has really has been shown to be highly effective. And so there's millions and millions of people suffering year after year. And this is real pain. It's not imaginary pain. It's not that it's all in their head, right? It's not imaginary pain. It's not that people are faking or they want the pain. It's not their fault. Most chronic pain occurs because the brain is generating neural circuits that are causing real pain. And it's, like I say, it has nothing to do with an issue that these people are mental or crazy. It's because they're human, and that's how the human brain works. When people get in difficult situations, their brain is likely to turn on pain or anxiety, depression, fatigue, insomnia as an alarm signal. It's like a built-in smoke alarm that we have. And, most doctors are really unaware of these far-ranging and revolutionary concepts.
Well, I think the situation that most of these people, find themselves in is being sent to the psych ward because there's absolutely nothing to show for their pain. And it's debilitating. So they're unable to continue with their daily lives. But that leads me to, is it correct in categorizing this pain as psychosomatic?
Psychosomatic would be a correct terminology for it. We don't use the term very much anymore because it has a pejorative meaning, or people think that we're blaming them, and we're not doing that at all. But, I've had many pains that were psychosomatic, or mind-body pains, or neuroplastic pain, or nociplastic is some of the more current medical terminology, neuroplastic or nociplastic pain, where the pain is real and it's occurring, but it's not physical damage in the body. And you're right, people are suffering because there's nothing to show for it. They look fine. Their tests are fine. Their examination is fine. If they have back or neck pain, their back MRI certainly will show abnormalities, but it turns out that everyone's back and neck MRI shows abnormality, even in the absence of pain, such as common spinal stenosis, degenerative disc disease, bulging discs. These are all seen in people who have no pain at all. So we look very closely at each individual to rule out a structural problem, but also to rule in a mind-body or a neuroplastic problem by looking at the characteristics of the pain. Because frequently, pain will shift or move. It'll turn on and off. It'll be in one place at one time, another place at another time. It'll be there in the morning or not there in the afternoon, or vice versa. Or it's okay when you exercise, but it hurts afterwards. Or it's triggered by the wind or sound or light or stress or the weather. So we look for all these clues that we've written about and we've done research on to determine if the pain is actually nociplastic, neuroplastic, mind-body pain, or if it's actually structural pain, which is certainly be the case. But most people with chronic pain have been through medical diagnosis and been through medical testing. And the doctors have looked for things like cancer and fractures or infections or tumors or inflammatory disorders. And when those aren't found, or they may have, a mild case of that, but that's not actually causing the pain, then, people become devastated, like you said, debilitated, and they have nowhere to turn to. And so we've done research showing that our methods can actually reverse chronic pain, as opposed to what most people are told: you have to manage it. You have to just live with it and do the best you can, and which is even more demoralizing to people when they go to the doctors, and the doctors and the psychologists and therapists say you have to live with it.
This stands out as the only concern that public health has with chronic pain, and that's management, not cure. It's not even really mentioned. Management has a monetary motive. Pharmaceutical industry obviously, gets a lot more from managing pain than having it cured and taken care of. It would seem that this might be the reason that methods such as yours are not mainstream. What are your thoughts?
Well, I don't impugn malintent to the medical profession. They're doing the best they can. They're doing what they've been taught. They've been taught that all pain is due to some bodily damage, so that's how they operate. They've been taught that there's no cure, so they help people manage it. They've been taught that the best thing you can do is do a combination of medication and physical therapy and injections and alternative acupuncture and exercise and all those types of things, and some kinds of talk therapy. And that's what they do. It's true that there is a large amount of money being spent on chronic pain. There's no doubt about that. And it's true that our methods are extremely low cost, low risk, low intervention. And it's true. Those things are true. But it's hard to make changes in something that everybody knows. When everybody knows the earth is flat, it's hard to tell people it's round. It takes a long time for those things to change, even though you can actually tell the earth is round when you watch a boat coming toward you on the horizon, because you see the top of the boat first, because the earth is round. I mean, it's amazing how simple that is to learn that. But it took, hundreds and hundreds of years, people looking at boats, hundreds and hundreds of years, and not recognizing, why do I see the top first before I see? If the earth was flat, you see the whole boat first, right? So I think we're in the same category. It's really not that complicated to recognize this type of work. Once you see it, you can't unsee it. And I can't tell you how many doctors I've seen and I've talked to, physicians, who had chronic pain themselves and who no one ever told them about this work. And then when they found this work, they got better. And now they can see it all the time. It's easy to recognize. But before they understood the concept, they weren't recognizing it in their own patients. So that's what and so it's not only physicians, but it's also patients. Patients often don't want to hear this. No matter how often and how loudly you say it's not your fault, you're not crazy, it's not imaginary, it's not all in your head, it's not because you want it. No matter how many times you say that, no matter how many times you say, we know, everyone knows your pain is real, and that it's coming from your brain, they oftentimes have a hard time hearing that and recognizing this message that it's not your fault, it's real pain, and there's hope for actually reversing it as opposed to just managing.
How does psychological stress contribute to the development and persistence of chronic pain?
Right, great question. So we know from many experimental studies that when someone gets a physical injury and you do fMRI scanning of their brain to see what parts of the brain are being activated or lighting up, when you get a physical injury, there's certain parts of the brain that are lighting up, that are being activated. When you give someone an emotional injury, the same parts of the brain are lighting up. So that means that our brains were designed as an alarm mechanism to alert us if we get injured, to give us pain, to alert us that we have to take your hand off this hot stove, or get help for the broken bone or the sprained ankle. But our brain also has the same mechanism in it to alert us when there's emotional stress or emotional injury, if we're being micromanaged at work, if our spouse is cheating on us, if our child is acting up or not going to school, if our next door neighbor is threatening us, if we feel trapped. All those things activate the same danger alarm mechanism in the brain that's inborn. Everyone has it. And it's not only pain, as I've mentioned several times, it's not only pain that this danger alarm mechanism can activate. It can activate fatigue, insomnia, depression, anxiety, all sorts of urinary frequency, diarrhea, ringing in the ears. There's tingling, numbness. There's all sorts of things that the brain can activate, and it's fascinating, kind of scary in a way that the brain can do that to you. But the brain is just it's actually trying to help us by saying, hey, look, there's a problem here.
Everyone experiences struggle, but it's only in particular cases where the chronic pain that has no tissue destruction and, that kind of evidence for the pain, not everyone experiences that as the end result. So are there particular psychological factors or emotional factors that are more commonly associated with developing chronic pain? Or more interestingly, and this is the two-part, but psychological profiles or personality traits, people that are prone to develop chronic pain?
Yeah, there are. There's no question about that. First of all, everyone has a brain and a body. So everyone gets some sorts of mind-body disorders in their life. We just oftentimes, they're not recognized. You wake up with a sore neck and you say, I slept wrong. Or you have a headache at the end of the day and you said, I didn't drink enough water, but it was actually stress in your life that was causing those things. And those are common, and those are usually self-limited. But there are several factors that can lead to persistence of pain and other mind-body or neuroplastic type conditions, and those are childhood trauma. The brain of people with childhood trauma is more sensitized, more likely to be on edge, alert, worried, fearful. People who have personality traits that are overly, it sounds silly, but overly kind and caring, overly dependent, overly putting everyone else first, never standing up for themselves, overly perfectionistic, overly conscientious, overly fearful. People who have histories of anxiety and depression are more likely to develop chronic pain. And people have more incidents of stressful conditions in their lives. Also, if your kids grow up and, they're doing fine and they play sports and they get all A's, there's a lot less stress than if your kid grows up and is flunking out of school and doing drugs. I mean, it's a huge difference. Or you have a child who's born with disabilities that are severe and cause a tremendous strain on the marriage. There's so many things that can lead people's brains to fall into this pattern.
Is there a scientific explanation because, contrary to a gunshot wound, it happens, you immediately feel that the physical pain is there as a direct result after the fact. With chronic pain that has a psychological origin, it's as if there are tiny incidents that accumulate to eventually developing this extensive chronic pain.
It can go either way. You can have people with childhood trauma and many, many stresses over their lifetime, and then at some point there's a tipping point at which time the pain kicks in. But oftentimes there's evidence of different pains starting at different times in their life. Maybe headaches as a kid, stomach pain as a teenager, maybe an eating disorder or diarrhea as an adult, and then later some more chronic pain like back pain or chronic widespread pain. But on the other hand, it can be very acute. I for example, this is a related topic, but long COVID or long haul COVID is a disorder where most of the people who have it had a COVID infection. Some people didn't even have a COVID infection, frankly. And that COVID infection cured because the virus, was taken care of by the immune system, assuming that you don't have a severe infection. Most people didn't have a severe infection, and they develop all sorts of fatigue, headache, can't concentrate, dizziness, pain, etc. And many of those people were perfectly fine. One of the most famous people who had long COVID was a very esteemed physician in Britain, Dr. Paul Garner, who was never sick, never had anxiety in his life, never had depression, never had chronic pain until he got COVID in the early time of COVID, and he has severe symptoms. And now he's perfectly fine using our model of changing his relationship to the symptoms, knowing that he wasn't actually damaged. The symptoms are real, but they're reversible, starting to move, starting to exercise, all these simple things, dealing with stress in your life. And he's perfectly fine. And we've helped, thousands of people with this whole range of illnesses that are non-structural. So it can be very acute, like, boom, a certain event happens and then the pain starts. Sometimes people will have a surgery. They'll have an operation. And after the operation, the pain, the surgery heals, or they have a car accident, the injury heals, but then the pain persists. So it can be fairly acute as well, and then become chronic, become persistent.
How do you even begin to approach the treatment of chronic pain in persons who have as the origin of that pain childhood trauma and psychological distress?
Well, we have a model. We have a model that we use, and we use it for everybody. And the first step in the model is validating, empathizing, sympathizing, listening, making sure that people know that they're being heard and that they're being cared for, and that we know that their symptoms are real and not imaginary. The second step is assessing them using the model that I talked about, looking very carefully and in a detailed way to make sure we're not missing some kind of structural problem. Out a structural problem, ruling in a neural circuit or neuroplastic problem. Then we're educating, like we're talking now, all the information that I'm giving you, educating people to how the brain works, why the brain can cause these symptoms, why they become persistent. Then there's 3 types of therapies that we use. One is called pain reprocessing therapy, that we can talk about what that is. The second one is emotional awareness and expression therapy. The first one gets at the neural circuits in the brain that are causing the pain and helping people to rewire their brain, turn off those neural circuits. The second one, emotional awareness and expression, is to deal with the underlying psychological or emotional issues and the underlying trauma. So we have ways of dealing with that. And the third type of therapy or third type of intervention is helping people make changes in their life that are necessary. I saw a patient just a couple of weeks ago who was having a very, very severe pain, could barely move, could barely get out of bed with back pain, could barely dress herself, turn over, could barely walk, so severe. And she was using the way, trying to explain to herself that she was okay, that she was not damaged, that she was not broken, kind of the tenets of the pain reprocessing therapy. It wasn't working for her. And one day she had this realization that she said, you know what? I don't think my marriage is working. I might need to leave. I might need an exit strategy. And the pain completely disappeared when she made that realization, this severe 9 out of 10, 10 out of 10 pain. So, we're working, and not everybody has to leave their marriage. But it so happens that, we look very broadly at how we can help people from what's going on in their life to what's going on in their past and their emotions and what's going on in their brain.
It's a harrowing subject that we're discussing, but what I do find very sort of, cathartic for human beings experiencing this is the fact that our bodies are primed to alert us of emotional turmoil. I mean, if we are producing pain to suppress emotional trauma, or alerts us thereof.
Mm-hmm.
It's a sort of a circular taking care of ourselves process that it's just, you have to find it beautiful.
It's kind of like, when a smoke alarm goes off, we don't get mad at the smoke alarm.
Yeah.
Even though it's very loud and annoying, it's there to help us. And pain is debilitating. I'm not trying to make fun of it or be glib about it, but nevertheless, if we can really look and understand that certain pains, not some pains are due to structural physical injuries. We know that.
Mm-hmm.
But again, most chronic pain isn't in our estimation. And therefore, having this understanding can make a huge difference away from trying to fight the pain to looking for the underlying causes of it so that it can be reversed.
Given the intensity of the chronic pain, one would assume that the emotions being suppressed would be proportionate in intensity. And that's just a daunting thought. So I think a lot of people would almost be deterred, to find out what the psychological origin is if it's comes close to the severity of the physical pain. Is there necessarily a correlation? Does it have to be equal? And
No, it doesn't actually. Not everyone has to do emotional or psychological work to reverse pain. They don't. The pain reprocess, a lot of times people had a car accident, an injury, and then the pain occurred, and then their brain fell into this vicious cycle of pain leading to fear of pain leading to focus on the pain leading to being frustrated with the pain, and that becomes a vicious cycle. So if we can help people understand that they're not actually damaged when that's the case, if we can help them to stop fearing the pain, stop focusing on it, stop being frustrated by it, which is admittedly not all that easy sometimes. But when they can do that, frequently the pain will go away in often a very short time without doing psychological or emotional work. There's a woman I saw who was a physician who started getting hand pain, both hands, both arms, both shoulders. Couldn't find help in the medical profession. No one could figure out why she had so much pain. It was so severe she had to stop working as a doctor. I mean, it was that severe pain for 3 or 4 years. And finally, she learned about our work. She came to one of our websites, read the materials. Her pain was down by 60 or 70% in one day after reading these materials. In 3 weeks, she was using one of the workbooks that we recommend, and her pain was gone in 3 weeks. So and it wasn't all this deep psychological work or anything like that. There may have been some psychological things originating it. Yes, of course. And as you pointed out, we all have some psychological stresses in our life, but the neural circuits of the brain just fell into this vicious cycle. And oftentimes they're not that difficult to unravel once you know what the cause is.
So is it pain reprocessing therapy? I'd like to get back to that. And that's sort of rewiring the brain.
Yeah.
So have we taught our brains to recognize pain, interpret pain in a particular way that is obviously very harmful to us? Is this neuropathic pain?
Well, neuropathic means pain due to damaged nerves. This is neuroplastic pain or nociplastic pain, where the pain is generated by the brain. Slight different in words, but it's an important distinction. And so, yes, what we're doing with pain reprocessing therapy is helping assess people and educate them and help them to turn off the natural responses that everyone has to pain, which is the fear of it, the focus on it, the frustration with it, the trying to fight it, all these things that actually fuel the pain, fuel the neural circuits in the brain that are creating the pain. And so when you start to turn those off and you start to, instead of moving, say a back pain or a shoulder pain, and you're moving with fear, waiting for the pain, knowing the pain's coming. Whereas if you totally shift that around and you start moving with calm, start moving with reassurance, start moving with joy even, you change the whole structure and function of the brain from a danger mechanism being alerted to a safety mechanism being activated. And so when your safety when the neural circuits in the brain for safety are being activated, that turns off the neural circuits for pain. And so everyone has this, you can experiment. Everyone can do that. You can think about stressful things and your shoulders hunch up and your body reacts and you tighten up. And you think about calming and soothing and kind and gentle and joyful and awe-inspiring things, and your body relaxes. I mean, it's just the normal reactions that we have that in chronic pain have taken, to somewhat of an extreme.
But if addressing the psychological and emotional cause of the pain is not necessary to reverse the chronic pain, is this not just a short-term solution? Will it not come back and make itself, known in the way that it can?
Right. Well, it's some people need to address the psychological underpinnings, as we mentioned with the woman who realized that her marriage was causing pain. So not everyone is going to be able to get better by just doing the pain reprocessing. Some people need the emotional awareness and expression therapy that we've developed as ways of dealing with their emotions, of recognizing that they really are upset or angry with their child, or they really are upset or angry with a friend who ghosted them, or they really are upset and angry with a parent or a brother or a sibling, or they really are feeling hurt and broken and guilty about things that they need to address. So absolutely. And you're right that the pain reprocessing can help people make the pain go away sometimes, but if there's deeper underlying emotional issues and new stresses occur, well, people may get pain in the future. But it's human to have pain. It's just part of being human. Yeah. Pain is part of the human experience. And stress is part of the human experience. So it's not surprising that people who recover from headaches may get back pain later in life, or they recover from stomach pain, they may get anxiety or fatigue later in life. But once we understand how to recognize these problems and deal with them effectively, then they're less likely to become chronic and persistent.
As you mentioned, these conditions and the pain, it often persists for years, sometimes decades, I think, because people are that out of touch with these alternative methods to approach them. And they've probably started staying away from doctors because no one could give them an answer, and that is very, very defeating. What are the effects of persistent chronic pain on both the brain and the body, respectively?
As far as we can tell, even with many, many years of chronic pain, the effects are not irreversible. The effects are not structural. The effects are not a damaged or broken body. The effects are more demoralizing, debilitating, devastating, suppressing. Those effects definitely are there. And people fall, and sometimes they fall into an identity that their identity is kind of wrapped up in being a person with pain. They recognize they can't do things, so they do less and less. They become sometimes more isolated, more withdrawn, less active, less joyful. It's a very, very hard thing to live with, and it can take all the joy out of life. So there's a lot of tremendous effects due to chronic pain, but they're not, as far as we can tell, they're not actually irreversibly structurally damaged.